Upon arrival to the emergency department, a cardiac profile would be ordered to establish baseline values. Then the cardiac profile would be ordered for several samplings in 3 to 8 hour intervals over a 12 to 24-hour period. Frequently, blood is drawn every 3 hours for analysis during the first 12-hour period. Laboratory testing used to assess AMI includes cardiac troponin T or I, CKMB, and sometimes myoglobin. In many institutions, once the cardiac troponin appears elevated, additional sampling and testing is halted, and the elevated cardiac troponin is considered diagnostic for AMI. Troponin, tissue location. Troponins T, I, and C form a complex of 3 proteins that bind to filaments of skeletal muscle and cardiac muscle to regulate muscle contraction. Clinical significance: cardiac troponin T or cardiac troponin. 1 is used as an AMI indicator because of specificity and early rise in serum concentration following AMI. In cases of AMI, cardiac troponin T increases in 3 to 4 hours following infarction, peaks in 10 to 24 hours, and returns to normal in 10 to 14 days. Cardiac troponin Y increases in 3 to 6 hours following infarction, peaks in 14 to 20 hours, and returns to normal in 5 to 10 days. Myoglobin, tissue location, found in skeletal and cardiac muscles. Clinical significance: increased in skeletal muscle injuries, muscular dystrophy, and AMI. Myoglobin is released early in cases of AMI, rising in 1 to 3 hours and peaking in 5 to 12 hours, and returns to normal in 18 to 30 hours. However, it is not tissue-specific. It is better used as a negative predictor in the first 2 to 4 hours following chest pain. Creatine Kinase and CKMB previously discussed in Section 6. Enzymes and Cardiac Assessment, pages 43 to 44. Natriuretic peptides, polypeptide hormones. Now let's dive into their tissue location and function. There are 3 forms: ANP, CNP, and BNP. Although their effects are minimal, they function to promote the excretion of sodium and water by increasing the glomerular filtration rate and decreasing the tubular reabsorption of sodium by the kidneys. B-type, or brain natriuretic peptide, also known as BNP, is synthesized in and secreted from the myocardial ventricles in response to ventricular volume expansion and pressure overload. BNP causes dilation of blood vessels and promotes sodium and water loss, thus reducing the fluid load on the heart to improve cardiac function. Clinically, BNP levels are increased in congestive heart failure, which is quite significant. Now, let's talk about the test methodology. BNP is quantified by fluorescence and chemiluminescence immunoassays. The reference range for BNP is less than 100 picograms per milliliter. There's also the proBNP assay, which measures N-terminal proBNP or NT-proBNP, released when BNP is cleaved from its precursor proBNP. NT-proBNP has a longer half-life than BNP. Measurement of NT-proBNP shows no interference from natriuretic, which is human recombinant BNP, administered to treat congestive heart failure. NT-proBNP is measured by electrochemiluminescence. High-sensitivity CRP, or hs-CRP, is a type of C-reactive protein, which is a B-globulin and an acute phase reactant. The term high sensitivity refers to the sensitivity of the assay used to determine low levels of CRP in serum. Clinically, hs-CRP is significant as it is used as a predictor for cardiovascular risk. Increased levels can be seen in conditions such as inflammation, infection, stress, trauma, and acute myocardial infarction. The test is quantified by immunoassay, with a detection limit of 0.05 milligrams per liter. The reference ranges for males are 0.3 to 8.6 milligrams per liter, and for females, 0.2 to 9.1 milligrams per liter. Cardiovascular risk is classified as low risk for levels less than 1.0 milligrams per liter, average risk for levels between 1.0 and 3.0 milligrams per liter, and high risk for levels greater than 3.0 milligrams per liter. Homocysteine is clinically significant because elevated levels can cause damage to arterial walls, which precedes the formation of plaques. It serves as an indicator of arterial inflammation. The test methodologies used to measure homocysteine include immunoassay, fluorometric, and chromatographic techniques. The reference range for homocysteine levels is 5 to 15 picomoles per liter. Liver function encompasses synthesis, excretory, and detoxification processes. The liver synthesizes proteins, coagulation factors, ammonia, carbohydrates, fats, ketones, vitamin A, and enzymes, among other substances. Bilirubin is the principal pigment in bile and is derived from the breakdown of hemoglobin. It is produced in the reticuloendothelial system from the breakdown of senescent red blood cells. Bilirubin forms a complex with albumin for transport to the liver, in which form it is unconjugated and not water-soluble. In the hepatocyte endoplasmic reticulum, bilirubin is conjugated with glucuronic acid to form bilirubin deglucuronide, or conjugated bilirubin. This reaction is catalyzed by uridine diphosphate glycuronyl transferase. Conjugated bilirubin is water-soluble and is excreted into the bile for storage in the gallbladder. It is then secreted into the duodenum in response to gallbladder stimulation and reduced by anaerobic bacteria in the intestine to urobilinogen. Some intestinal urobilinogen is reabsorbed, with a portion returning to the liver and some entering the circulation for excretion in the urine, while the remaining portion in the intestines is oxidized by anaerobic bacteria for excretion in the stool as urobilin. Urobilin is an orange-brown pigment that gives stool its characteristic color. Jaundice, or icterus, is a yellow discoloration that occurs when the bilirubin concentration in the blood rises above 2 to 3 milligrams per deciliter, and the bilirubin is deposited in the skin and sclera of the eyes. Kernicterus is a condition where elevated bilirubin deposits in the brain tissue of infants, affecting the central nervous system and potentially resulting in mental retardation. The liver also secretes bile to assist in digestion. Bile salts are composed of cholic acid and chenodeoxycholic acid conjugated with glycine or taurine, and bile is stored in the gallbladder. The liver is the primary site in the body for the synthesis of waste products such as urea, the conjugation of hormones and bilirubin to water-soluble forms, and the conversion of drugs to metabolites for excretion in urine or stool. Jaundice can be classified based on its causes. Prehepatic jaundice occurs when there is excessive erythrocyte destruction, as seen in conditions like hemolytic anemias, spherocytosis, toxic conditions, and hemolytic disease of the newborn caused by Rh or ABO incompatibility. In these cases, the rate of hemolysis exceeds the liver's ability to take up bilirubin for conjugation, leading to an increased level of unconjugated bilirubin in the serum. Hepatic jaundice occurs when liver cells malfunction and cannot take up, conjugate, or secrete bilirubin. Examples include Gilbert syndrome, which is a defect in the ability of hepatocytes to take up bilirubin; Crigler-Najjar disease, which involves partial or complete deficiency of UDP glycuronyl transferase; and Dubin-Johnson syndrome, which is characterized by defective liver cell excretion of bilirubin. Neonatal physiological jaundice occurs because the level of UDP glycuronyl transferase is low at birth and takes several days to reach adequate levels. Intrahepatic cholestasis can be caused by hepatocyte injury, bile duct injury, or neoplasms. Posthepatic jaundice occurs when an obstruction blocks the flow of bile into the intestines, referred to as extrahepatic cholestasis. This can be caused by gallstones, neoplasms such as carcinoma of the ampulla of Vater or carcinoma of the pancreas, and inflammatory conditions like acute cholangitis or acute pancreatitis. Posthepatic jaundice is characterized by significantly increased levels of conjugated bilirubin in serum, increased unconjugated bilirubin in serum, increased conjugated bilirubin in urine, decreased urine and fecal urobilinogen, and pale-colored stool.